Recording now. Excellent. So hello and good evening, everyone. Hope you all are doing well. Welcome to Emerging Issues in Appalachia, Lessons from Healthcare Advocates, a new virtual advocacy presentation series. My name is Emmett Huck, and I'm a fourth-year medical student at WVU School of Medicine, and I'm the president of SAIDOH, which is Student Advocates Impacting Decisions on Healthcare, which is a healthcare advocacy student organization at WVU. Before we start with tonight's 4 presentations, I want to first thank you all for joining us. Here we have an audience of medical students from WVU, Marshall University, and West Virginia School of Osteopathic Medicine, and students from the other health sciences professions, residents, faculty, staff, and colleagues. Thank you all for joining us. We're really excited for this event. And for those unable to join with us this evening, like I said before, we will be recording and uploading this event to YouTube at a later date. These 4 presentations will be approximately 20 minutes each, with about 3 to 5 minutes after each presentation available for audience questions. Just some info on SAIDOH. So SAIDOH was started in 2017 by a group of WVU medical students who are now residents. I want to give a quick shout out to Dr. Jessica Thayer in the audience, who's a current internal medicine resident at WVU, and who was one of the students who started SAIDOH and introduced myself and many of our current group to student advocacy. Our goal in SAIDOH is to educate medical students regarding advocacy and to examine healthcare policy as it impacts physicians and their patients. To do so, we work during the year to organize events such as Advocacy 101, social media, and op-ed writing workshops, in addition to what we call our fireside chats, which are more intimate conversations with advocates across the state to discuss their experiences and their advice. Past fireside chats have included WVU neurologist Dr. Dave Watson, NIH epidemiologist Dr. Priska Majuru, and immediate past president of the American Medical Association, Dr. Patrice Harris. And in the pre-COVID times, what I guess you could call the real BC times, SAIDOH members have traveled to Capitol Hill to meet with West Virginia's elected legislators, including Senator Capito and the office of Senator Manchin. We're hoping to organize a similar trip for spring 2022. The idea for this event, Emerging Issues in Appalachia, evolved from the fireside chats we've hosted in the past. Our current officers, which include Vice President Sarah Berzingi, Treasurer Sundus Latif, Secretary Hunter Barclay, Charleston Campus Liaison Zach Bonham and Vanna Lusk, Eastern Campus Liaison Shreyas Menon and Ella Bushman, in addition to our faculty advisor and an advocacy role model for students, Dr. Lisa Costello, had discussed organizing a larger, more open type of event with presentations to hopefully lead to more interactions between the student groups of the 3 medical schools here in West Virginia. Tonight, we will have presentations from 4 professionals in West Virginia of different areas of expertise and experience. Our presenters will share on topics that we may not see or experience within the immediate clinic or hospital environment. We believe that these unique experiences can add insight to and inform our holistic patient care approach in Appalachia. On patient care, I've learned 2 very important lessons as a medical student about what a career in the field entails. One is that patient care is not limited to the perimeter of the 4 walls of a hospital or clinic. The clinical environment is a controlled, sterile setting where we have an immense amount of control over the care our patients receive. However, outside, that's where real medicine happens. That's where we see if the antihypertensive medications work, where we see if discussions on whether to get vaccinated happen at dinner tables or between church pews, where patients have to coordinate multiple appointments and task lists with work, childcare, and bills, and where the real life-changing events happen. The most effective healthcare providers are those who consider the patient as a whole, not as the objective sum of lab values plus imaging studies plus textbook diagnostic heuristics. 2, the second lesson is that it's never too early to be an advocate, and being an advocate is not a cookie cutter approach. Advocates are clinicians, they are researchers, they are fire chiefs, teachers, local officials, and they are the neighbors and the people behind you in the grocery line. Advocacy happens in the op-ed section, in the classroom, in the town hall, in the lab, and on social media. Our 4 presenters tonight highlight the value of experiential diversity and advocacy. I hope that tonight everyone in attendance can not only learn about 4 specific healthcare issues affecting Appalachian patients, but also to start reflecting on how we as individuals can begin our own personal advocacy journey and can contribute in our own unique way in our own specific area to the bigger picture. Now, without further ado, Sundus Latif will be introducing our first presenter of the evening.
Thank you, Amit. It is my pleasure and honor to introduce Dr. Sally Hodder. Dr. Hodder is an infectious diseases physician, professor of medicine at WVU, and Associate Vice President for Clinical and Translational Science and Director of the West Virginia Clinical and Translational Science Institute. Prior to assuming these roles, she served as Vice President of Virology Medical Affairs at Bristol Myers Squibb, where she was responsible for 118 phase 3B and 4 trials worldwide. Dr. Hodder established an HIV prevention trials network in New Jersey, where HIV prevalence was nearly 3% among the African-American community. Dr. Hodder has since brought her expertise to WVU, where she and her team have been awarded record-breaking funding for research in our state, including millions of dollars in NIH funding to tackle issues such as COVID-19 and HIV in Appalachia, affecting the most vulnerable and underserved people of West Virginia. Outside of her work as a researcher, she fosters the careers of future scientists and physicians and is one of my dearest mentors. Please join me in welcoming Dr. Hodder.
So as usual, I am having difficulty here sharing my screen. And I think probably in the interest of time, Sundus, if you would just, oh, there we go. Okay. All right. So I'm going to talk a little bit about HIV coming to the heartland. Next slide. These are my disclosures. I serve on several advisory boards for antiretroviral companies, and we currently have clinical trials. The ViiV trial just closed, and we have a Merck trial, very good trial of HIV prevention drugs, PrEP in women who use drugs. Next slide. So just for the medical students, I grew up at Appalachia, and I went to medical school, and then I trained at UCSF. Because I thought it would be fun to live in San Francisco. I mean, that's how I made my decisions. And I had no idea, you know, people say, oh, you should, what do you want to do with your career? Where will you be in 10 years? That has never worked for me because stuff happens. And what happened to me, as I was finishing my internship in San Francisco in 1981, I started in July of 80, there were back-to-back reports in the MMWR about these, you know, weirdo infections. Well, I had seen those infections all year and many more in particularly men who have sex with men. You know, sort of gay bowel syndrome was an accepted sign-out diagnosis in the San Francisco General Emergency Room. We had no idea what we were looking at. After 4 years of medical school and a year of internship. And then these back-to-back reports came out, and I knew instantly, that's what was going on, and this was going to be big. Next slide. And big it was. It was, those early years were a death sentence. After, you know, doing my residency and internship and seeing all of this, how could you not go into infectious disease? I trained in infectious disease, but of course, there were no drugs. All of our patients died. The professors would go see the endocarditis patients on rounds and so forth. But then the fellows, we just had our own HIV services at that time. You know, these individuals would die alone, paper trays. Nobody would want to go in the room. I mean, it was really a scourge, and it just colored my whole view for the rest of my career. Next slide. But what was really amazing is it wasn't very long before we started to understand, number one, what the virus was, number two, the life cycle shown in this cartoon, and number three, then when you started to understand the life cycle, then you could find compounds that would inhibit various steps, and you could start to say, can we treat this? Remember, you know, 95% plus of people would die, and all my patients that were dying in the 80s were, you know, folks who were young and in the prime of their lives. And at that time, I actually, to get away from it, actually went and lived in Africa. I worked on a schistosomiasis project, Coast Province, Kenya. It was gorgeous. Initially, I thought it was me. AIDS at that time was first described exploding in Africa, and it was clear it was all over. Next slide. But what was really interesting, when I came back to Cleveland, we had a trial with Caseman, one of the earlier protease inhibitors, and it was found you couldn't just inhibit one area of the HIV, you had to inhibit multiple areas. So protease inhibitor to inhibit the protein packaging, and reverse transcriptase inhibitors, and you put them together. I had a guy who was about 6'3" and about 95 pounds, and that guy came back from the dead. Honest to God, I remember where I was. We got him in the trial. 2 days later, we started to eat, and I didn't need to go to the retrovirus meeting that year. HART is highly active antiretroviral therapy. As it went up, deaths plummeted. All at once, there was a future, and we were really in business. Next slide. And not only did antiretroviral therapy save lives for people who were infected, this was actually a study from the HIV Prevention Trials Group that gave folks who were infected and had a seronegative partner, they randomized them to immediate or delayed antiretroviral therapy. And if you go to the next slide, you will see that actually the single transmission that occurred in the immediate arm was in a person that occurred too close to the time that antiretroviral therapy was started in their partner. At the antiretroviral therapy at that time, it took months to get undetectable. With the new integrase inhibitors today, people are undetectable within weeks. Next slide. And indeed, this was the breakthrough of the year in that year. And it was 2011. The study was done a few years before. And not only could we treat, but we could prevent HIV. If you had an individual who was undetectable, that was untransmittable. And so that was big. Next slide. But then in 2013, 2014, there were reports in Scott County, Indiana, in Appalachia, of 181 cases, 43% women, most were white, and most were injection drug users. And if you can look, this was really associated in a part of the state of Indiana with a high poverty rate, and a fifth of individuals were without a high school diploma. Next slide. And of course, this was written up in the New England Journal of Medicine. This was oxymorphone. That was the drug that was most commonly seen in that outbreak. And if we go to the next slide. This, I think, really was the start of sort of an understanding in this country that we had a huge problem. Now, it had been increasing before, but you can see that the mortality rate, these are opioid overdose rates, were just skyrocketing by 2013. It looks like they come down in 2018, but I can tell you 2019 is right back up. And in the previous year, 2020, we have had the highest overdose death rate that this country has ever seen. I think the pandemic has made it worse. Next slide. And, if you look, people talk about 3 phases, but I want to sort of call your attention to the fact that the synthetic opioids, fentanyl, carbofentanyl, are really the drugs that are really sort of driving the accelerated overdose death rate. And you'll see why that's relevant. Those drugs are also driving HIV. Next slide. I just wanted to sort of step back and put everything in context. If you look at heat maps looking at overdose mortality rates, this only goes to 2016, but as I said, it's only gotten worse since then. You can see that this is really from 1999 till now. Really, the whole country has seen an increase, with hot spots here in Appalachia, as well as in areas of the West. Next slide. And if you overlay the drug overdose death rate with poverty, you can see that there is really much of them mapped. So this is really, I think, a societal problem. It is a problem that has got to have a very sort of integrated, large, sort of response. It's not a matter of just getting somebody into MAT. Next slide. And just at this time in 2014, and by the way, I had actually progressed. I worked for the pharmaceutical industry for a while. I was VP of Medical Affairs as we brought a protease inhibitor to market. It was a fabulous experience. I think most physicians have no idea what it takes. I certainly didn't, but it was really eye-opening. And then I ran a big HIV program in Newark, New Jersey. Now that's relevant because Newark, New Jersey had a prevalence, as Sunda said, about 3% in the Black population, no adult treatment trials or anything. But the thing about Newark is they had the highest percentage of cases that were women. Why? Because the HIV epidemic in Newark, New Jersey originated in the injection drug users rather than the MSM, the men who have sex with men group. And many of the women in my clinic actually had been infected through heterosexual transmission. Some of them, of course, were users, but many of them were not, and they had no idea that this would happen. And this is relevant because I think this is going on and will go on in West Virginia now. So in 2014, this was a slide, a presentation from the CDC. I said, have you guys published this yet? And they keep saying they're going to, but I don't have the reference. I don't think they have. But it's very true that you saw an inflection. Whereas Black African Americans had formerly been the group who most likely to have new HIV diagnosis among injection drug users, this actually had a transition. It was white individuals, it was younger individuals, and for the first time, if you look at the bottom panel on the right, you can see that it was individuals outside of metropolitan areas. And if you look at the panel on the left, you know, it was known in the 80s that injection drug use was a risk. And actually that was addressed, and the rate, this is only from 2010, but it really come down very sharply in the 90s. And it has, in more recent years, plateaued. It really ticked up a bit in 15, has really come and plateaued down. But I think that that's really also a red flag. Next slide. And this is just makes the point that my last slide makes, that individuals, if you look at diagnoses of new HIV infections, their infections are mostly among white individuals. If you look about women who have new diagnoses in the United States, despite the fact that Black women constitute about 13% of the population, they constitute 2/3 of individuals with new HIV diagnoses. However, most of the transmission in Black women is heterosexual. In white women, about 25% actually is from injection drug use. Next slide. And this is the point I made earlier. These are new HIV diagnoses, 1985 to 17. And you can see how that's come down quite nicely, but plateaued in more recent years. Next slide. Now, getting to the fentanyl, which is a real problem, it not only is really responsible for much of the overdose death, but it is available as a powder, and it allows cold preparation, so you don't have the heat that inactivates the HIV. It is, there's less rinsing of syringes since they don't clog. There's more frequent injection. You know, fentanyl goes up fast, but it comes off the receptors, and people crave and will have multiple injections a day. And it really is increasing frequency of injection and needle sharing. And obviously, you know, the polydrug use, it's often contaminated with methamphetamine, and obviously stimulants are a major issue today as well. Next slide. So this was from the DHHR. I got this actually last March, but if I call your attention to 2019, you'll see that there were 78 infections in just those 2 West Virginia counties among people who inject drugs. Believe it or not, and believe me, I checked it with the New York Department of Health because I just put this in a grant. Believe it or not, this is more new diagnoses among people who inject drugs than the 5 boroughs of New York City. I mean, I think that is unbelievable. Next slide. And it's not only, if you look at recent outbreaks, whether they are in Seattle, Washington, where they have a lot of HIV prevention programs, or in Massachusetts, there's some similarities. Most of the people inject drugs. Most of the people are white, and almost half the people in Seattle, actually 70%, are women. And I think that that's really something. I think women with HIV prevention have really not gotten the attention and the emphasis that is deserved there. Next slide. So why does this happen? This was from the CDC, and it showed actually it was just surveillance testing folks who reported that they had, injected drugs. 6% were HIV positive. Only a little over half had been tested in the past 12 months. And, condomless women were among those who inject drugs. And a sizable percentage of those women also had anal sex, i.e., condoms aren't going to do much there. Next one. Barriers to HIV testing. You can see the list. And I think all of these are important, and you can see some common themes here. Poverty, we know that drug overdose overlies that. And actually, it is very difficult in these areas for people to access healthcare, to really have, the ability to, you still have to get a bus ticket, or in West Virginia, God knows how you get there, right? And so it's not just one thing, and stigma is a big issue. Next slide. Just moving on to syringe service programs. We know how to prevent HIV. We know how to prevent it. We know that syringe service programs prevent it. This is a meta-analysis that was conducted, that when they put all these studies together, it's with 12,000 patient years, it's certainly demonstrated evidence that it prevents transmission. Next slide. And this is another more recent paper from Monica Ruiz out of she's a George Washington now. And this looked at Maryland, and you can see that when the laws changed in 1994, that red line there, that almost 1,900 HIV cases were averted over the 10 years that syringe service programs were implemented. And when they did a return on investment, unbelievably, but I read the paper, it was almost $47 million. I mean, the most important thing is really preventing HIV infection and preventing death and, preventing disease. But, when people argue that, oh, we don't have the money to do this, what we really should be saying is, if we don't do this, we will really be spending a lot more money. Next slide. In Scott County, there have been several modeling studies. Its cases would have been limited to less than 56 folks if, when they started to see these cases, they had implemented syringe service programs. If the intervention had actually been available in 2011, we wouldn't have even had the outbreak. So think about that. Next one. The problem is that there are all sorts of barriers. And remember that syringe service programs, clean syringes, not only prevent HIV, they prevent hepatitis C, they prevent, hepatitis B. So it's not just HIV. And yet there are very few places, if you look at the CDC vulnerable counties, these were 280 counties most likely to suffer HIV and hepatitis C outbreaks, several of which were in West Virginia, that, the availability of syringe programs was sparse. And obviously with the recent passage of laws in West Virginia, I think it really makes syringe service programs even more difficult to operate, and several have closed in the midst of having a clear HIV outbreak here. Next. Now, not only, when I showed that slide that actually antiretrovirals can prevent transmission from heterosexuals, they actually did a study in Bangkok. It's been one of the few studies that was ever done in folks that inject drugs. And it actually gave tenofovir to individuals who injected drugs versus placebo. And as you can see there, that tenofovir actually decreased the transmission of HIV. And if we go to the next slide, overall, it was a 49% decrease. But look at the bottom line. There weren't that many women, so the p-value is a little bit bigger, but it was 78.6% effective there. Women on the needle, usually they're the second on the needle. They're much more likely to have syringe, sharing. Number two, the power, sort of a relationship. Usually, women frequently have sex. They'll have sex because they don't have money to get the drugs, or they'll be in a power relationship where they really have no choice. And so, I think that particularly women who use drugs, we really have to have special programs because I think they're at special risk. Next slide. There are all sorts of barriers to people who inject drugs. There was a study done over in Kabul that 69% of individuals had not previously heard of PrEP. We just opened a trial. We're comparing tenofovir to islatravir. Islatravir is a new wonderful antiretroviral. It's only once a month. Will it work with PrEP? We'll see. But when we're recruiting in the Coat Clinic over at Behavioral Medicine, and when I talk to these women, I talk to their group, there is absolutely no understanding or knowledge that actually PrEP exists, or even that they're at risk for HIV. And, I think that that's really a major issue. Next slide. So I'm not going to, read the conclusions, they're there, but I think the bottom line is that there is an enormous problem in West Virginia. I think that there has not been the political will to really deal with it. And I think that there is so much advocacy that needs to be done. And particularly, I think there need to be programs to really understand what women need and serve them. And I'll stop there and thank you.
Thank you so much, Dr. Hodder. Just opening up the floor to any audience questions, any questions for Dr. Hodder in her presentation.
I have a question. I know, Dr. Hodder, you were telling us about some of the steps to move forward. Is it expanded PrEP? Is it talking to more women at COAT? Is it advocating on our state level to try and reopen these harm reduction programs? I was thinking, just as a medical student, or even, going into residency, burgeoning physicians, what advice you would have for us in terms of advocacy in this respect for Appalachians, or just in general at our stage in our education?
Yeah, let me tell you a little anecdote that happened to me as a medical student. I don't think this would happen to any of you today. Back when, sort of prehistoric times, pyelonephritis was admitted, and I had a lady admitted who, and the medical students, we stayed all night. You had to do this history and physical, all this stuff. And she was an alcoholic. And I went to Case Western Reserve, and, we had to do all these experiences. We had to see Lester Adelson do a violent homicide autopsy. We had to go to AA. So I knew there was AA. I said, listen, let's go to AA together. And I talked to her about that. Do you know, this is unbelievable. She became sober, and I got a Christmas card every year from her until a couple of years ago when she died, saying, you saved my life. And so the point of that story is I think all of us in one-on-one encounters minimize the impact you can have on somebody to meet them where they are and really sort of talk to them. Now, a lot of times it doesn't happen. I understand that, didn't happen to me again in my career. But I think that that's number one. I think number two, yes, there needs to be advocacy, but it's not only syringe service programs. I think it's really programs around treatment, getting people into medically assisted treatment. Remember, 50% of those folks will relapse. We need better treatment modalities. We need to address the poverty. We have a study we did in 95 women, just talking to women who use drugs, and the need there, the hierarchy of need. Of course, they're not worried about HIV. They're worried about safety. There's no place to live. Somebody's beating them up. I mean, I wouldn't worry about HIV either, you know? So I think really meeting those needs, you have to do that before we can really sort of make some progress on the other side.
Thank you so much. It's inspiring to hear the story that you told, because it's an impact that a medical student can have when we build these relationships with our patients and inform them and just be with them where they are is really inspiring to hear.
Yes, thank you so much. Really beautiful anecdote and wonderful presentation. Any last questions before we proceed? All right, I think next, thank you again, Dr. Hodder. Next, I would like to introduce Chief Jan Rader, who's the Chief of the Fire Department of the City of Huntington, West Virginia. Chief Rader has served in the Huntington Fire Department since 1994 and was the first woman to lead a professional fire department in our state. In addition, Chief Rader has also worked as an ER nurse, and for years she has been a leader in the state's response to the opioid epidemic. Her strength and compassion for those affected by substance use and for the other first responders who every day face unprecedented physical and emotional strain are among the many reasons that Chief Rader was named to the 2018 Time Magazine 100 Most Influential list. I also recommend for anyone in attendance to watch the 2017 short documentary Heroin, which features Chief Rader and the department in Huntington. So now over to Chief Rader.
Thank you so much. I'm going to try to share my screen here. Nope. Did it work? Yes.
Yes.
Okay, fantastic. Okay, thank you. And it's quite an honor to be asked to speak with you all. And I appreciate what you all are doing. And I love your enthusiasm for learning and for doing the right thing, which is huge in the medical community, in the helping profession in general. And I must say that Dr. Sally Hodder is one of my heroes. So she's a hard act to follow. So, you know, I'm going to talk a little bit about how a community can come together and make positive changes during an opioid epidemic. And, you know, there's struggles and there's things we've learned, things we know that we can't do. So just to give those who do not know a little background, you know, Huntington is where Kentucky, Ohio, and West Virginia meet. It's the second largest city in West Virginia. It's comprised of 46,000 people. It's the county seat of Cabell, and Cabell County has a population of 92,000. Of course, we're home to Marshall University, and we do have 2 level 2 trauma centers. Okay. So just a little introduction. Of course, I don't need to tell all of you how exactly the opioid epidemic got started in heroin. There's plenty of literature out there. I'm sure you all have had quite the education on this. And you're fortunate. You know, I'm an old paramedic, and I went to nursing school at age 40, and I was taught nothing about addiction in general. And I'm very proud of the street level education that I have. And I think it's imperative to listen to your patients and listen to those suffering as part of your educational process. So I actually pretty much in my career have watched it unfold. So one thing that you have with heroin, you know, I just showed you a slide, you know, when you have people that are using drugs or suffering from substance use disorder, there are things that happen. You know, of course, you have poverty and all that. They lose jobs, they lose their housing, and of course, they steal. And so property crime goes up right along with heroin sales. And that's one thing that we have tracked here in Huntington, West Virginia. Our mayor figured out, he came to realize in 2014 that we could not arrest our way out of this, you know, because drug addiction in general for 50 years has been treated as a criminal problem, and it's not. It's a healthcare issue, and thankfully we are moving in the right direction. If anybody hasn't read the book Dreamland, I recommend that. Sam Quinones wrote that. It's a really good book. It tells you how drugs are moved from one location to another. It's no longer you go to a crack house to buy drugs or whatever, it's on the move. They meet anywhere. They use where they buy. So whether that's a gas station bathroom or the bathroom of Starbucks, and I've been on overdoses at just about any place that you can imagine. But just to show you how things escalated very quickly, this is a heat map of Huntington and drug crime in the year 2004. And so in essence, if you wanted to make a difference or stop drugs in Huntington at that time, it was centered around Cabell Huntington Hospital, around where the medical school is. And it was like a 4-block radius. Well, because of how drugs were moved and the opioid epidemic, most people starting with a legal prescription to a narcotic and then moving on to heroin, this is what we had in 2014. So I don't know how, where do you start with combating that? So with so many people suffering. So in the fall of 2014, Mayor Williams started what we call the Office of Drug Control Policy. And so the 3 of us were put together, myself as a nurse, an ER nurse and firefighter, was a captain on the fire department at that time. We had a retired police officer or police chief was actually the director of our office. And then we had a statistician, a crime analyst for the police department locally. And we started going around and talking to people on the front lines, physicians, emergency rooms, health department, homeless shelters, you name it. We talked to them. And we found that there were so many people doing good things, but they didn't know about each other. And people were actually working in silos and they were afraid to ask for help. So we started connecting everybody together and facilitating talks and collaborations. We also put together a PowerPoint and we began educating the community. We started with the faith community because we thought we knew we needed harm reduction and syringe exchange, but we thought they might, they could either be our ally or they could be with us or against us. So we started educating them first, and not one person turned us down or said, I'm against this. So we moved on to business, and we spoke to CEOs at both hospitals and mental health, you name it. We even reached out across the river to Lawrence County, Ohio and Ashland, Kentucky, because a river is not a barrier to those suffering from substance use disorder. So one thing that became very evident is nobody was keeping real-time data. So the data that we would get, whether it was for new hepatitis B cases, new hepatitis C cases, HIV cases, it was 2-year-old data. And same with our overdoses and our overdose deaths. Well, it was moving so quickly, we could not affect change without knowing exactly what we were dealing with. So the first year that we actually kept real-time data, and it wasn't vetted data, but it was the basics by which we could affect change, was 2015. And that year we had 944 overdoses in the county, Cabell County, and 70 resulted in death. Medical complications associated with IV drug use, obviously, you know all about that. Overdoses being right at the top of the list, spread of bloodborne pathogens, hepatitis, HIV. We had a cluster. We had a cluster here in Cabell County. We got that under control very quickly. But simple complex infections, endocarditis, so many different effects of this. The collateral damage is huge, not only on the medical front, but on the mental health front and economic also. So West Virginia, one of the highest rates of new hepatitis B and C cases in the country. You have your outbreaks. We did a quick, it wasn't sanctioned or anything, but we conservatively started estimating, knowing what the costs are for hospitalization on endocarditis patient, cost to treat NAS babies, and so on and so on. We conservatively estimated that Cabell County, and the two hospitals probably treat or service a metropolitan area of maybe 360,000 people between multiple counties. We probably spent over $100 million in 2015 just on medical complications from IV drug use alone, and that's huge. So this little slide just shows you where we sit as a city and as a state, but obviously the city of Huntington had a really bad year in 2015. But wait, it just got worse before it got better. In 2016, we had 1,476 overdoses and 132 overdose deaths. The first 7 months, we were actually doing better than we did in 2015. But what happened was, most people are aware of a fateful day in Cabell County in Huntington, West Virginia, which was April 15th of 2016. And that was a day a gentleman came into Huntington from Akron, and he gave out free samples of carfentanil. And we had 26 overdoses in a 4-hour period. And each one of those individuals was saved in the moment that day with naloxone. Now, one died because he wasn't found until the next morning. He had used alone, but 911 was not notified. And by that time, we had started a harm reduction program. We got naloxone in the hands of all our first responders, which was responsible for making sure that 26 lives were saved in the moment on that fateful day. But nobody was saved long-term that day. In fact, multiple people who overdosed that day ended up dying from an overdose in the next few months. And that's where we knew that we failed 26 individuals, and we need to do more. I feel like this problem is a giant onion, and we peel back it layer at a time. And each time we do that, there's a new tender layer and something that we didn't realize. So the last 5 months of 2016, 80% of our overdose deaths involved some type of fentanyl. And that's where the real battle began with fentanyl. Of course, Dr. Hodder mentioned the study done by the CDC for 220 counties throughout the nation that are most vulnerable to HIV or hepatitis C epidemics. And 28 of those counties lie within the state of West Virginia. So even as early as 2015, we knew where this was heading. And that's why we were working desperately to change that statistic if we could. Heat map, this map just shows you where we stood. We had the highest death rate from overdose in 2015 in the country. So obviously this is a national issue. So no matter where you choose to practice medicine, this is going to be something that you will deal with. I think that there's probably a very high percentage of people who are admitted into both local hospitals here that have at least a secondary diagnosis of opioid use disorder or substance use disorder. So it's something real that we need to start dealing with anytime we have interaction in the medical community. We need to start working on this issue with people. This one deals with fire departments. I'll just mention it. I do a lot of speaking engagements with fire organizations as well. Most people that are treated in hospitals or taken to the hospital by ambulances do not have insurance. So there's a lot of unpaid bills that don't get paid. And that trickles down economically. I remember having a serious conversation with Gordon Mary. He's the director of Cabell County EMS here in Huntington. When we were in the midst of this, I think it was 2017, and we weren't sure that our organizations were going to be able to survive financially from this epidemic. It hurts with recruitment and retention issues. compassion fatigue and burnout. PTSD is huge with your first responders, because we don't just go on overdoses, we go on the same person over and over and over again until we find them dead. And we feel like we don't have the tool set to deal with that. You know, we're trained to save people's lives, and we just don't have the means to deal with that. I actually have multiple firefighters who have been on so many of their classmates' deaths that they're just completely iced over from it. And so we are working on that. You know, as healthcare providers, I want to stress to you, take care of yourself. You know, I wouldn't be surprised if every one of you have been touched by this, whether it's in your family or friends. You know, it's just, it's so widespread. So please take care of yourself physically and mentally. This is just a comparison, but basically the year 2000, the big thing to keep in mind here is the year 2017 was our peak here in Cabell County. And my fire department went on almost 1,500 more runs than they went on in a 10-year average, which is an extra wear and tear on not only the members of the department, but on the equipment. And you know, a fire truck, it costs you $500,000. It's not cheap, and it's public funds that purchase them. So compassion fatigue is huge. So please, please, please take care of yourself, because as a healthcare provider, I would be willing to bet that with physicians, just like it is with firefighters, we're really macho and we don't need any help. And so there's a stigma for us associated with that, and we need to get through that. So community partnerships are huge. You know, as a physician, you know, don't hesitate to reach out to people that can help you with what you're going to be dealing with your patients. And I can honestly say, you know, Dr. Hodder in her little, what she talked about, the patient she took to AA, kindness is everything. You have a lot of people that are suffering from substance use disorder that have been treated horribly by the medical community. They've been treated subhuman in many instances. And, you know, an act of kindness goes a very long way. And they have nothing. They are stigmatized. They are embarrassed, and just showing kindness can make or break them. And that's why I love our local harm reduction program here in Cabell County. It's run, Dr. Michael Kilkenny is in charge of it, and it is amazing. But it's the one place those suffering who have been thrown away by society can go, and they're loved on, and they're treated with dignity and respect, which they deserve. So I can't stress that enough. But always work with everybody. Don't stay in a silo. It's very important, because community partnerships lead to wonderful things, and we've shown that here in Huntington. At the end of my presentation, I have links that you can read about what we have done here in Huntington. And they've done studies on what we've done here. People come from around the country, leaders come from around the country to see what we're doing here, because we are making a difference. But it's a wonderful thing, and I hope we continue it for years to come. Quick response team has been huge. That is a team of 4 people that go out daily from noon until 8 p.m. and they meet with people within 72 hours of their resuscitation from an overdose. You have a paramedic, somebody in the mental health community, and it's typically somebody who is in long-term recovery themselves. We have an undercover police officer, and we have somebody from the faith community, and they have special training and to help guide them with their spiritual needs at all. Also, they knock on their door, they say, hey, we understand that you overdosed the other day and we don't want you to die. And here's programs that we have available, and we will help you get the help you need. about 30% of the people who they encounter are taking them up on their offer. And to me, that's a win. We also have PROACT, Provider Response Organization for Addiction. If you ever get a chance to come down and look at it, please do. One problem that we have is if you are suffering from substance use disorder and you walk into an emergency room or you're taken in by ambulance because you overdosed, you might sit and you want help. You might sit there for 18 hours until they try to find you placement. PROACT is a freestanding facility, so we're not clogging our emergency rooms. And if you really want the help, you don't have to have insurance. You can be plugged into some type of help within 2 hours. And that's huge. And that goes back to meeting people where they are, because sometimes when they ask for help, that window is very small. And if you turn them down on that time, they might just give up completely. We have Project Engage, and that involves both hospitals and people being approached and their substance use disorder dealt with while they're in the hospital for that or another issue. We have moms, maternal opioid medication support. If you have a baby born with neonatal abstinence syndrome, we can start the baby immediately on MAT so that they can still stay and visit with that child. They can also move from there to Project Hope for women and children, and that is a facility next to it's actually catty corner from my fire department, but it's 18 apartments where a mom can stay with her children while she's in a program for up to 6 months. And after that, they have aftercare. They have apartments where they can go and still get counseling. And it's intensive, but it's very rewarding for those that do it. And that's part of the support that we're trying to give to women who may be stuck with an overbearing drug dealer, or keep them from taking that baby back into a drug infested home. And of course, we also have Compass Navigating Wellness. That's a program we started for first responders in dealing with their compassion fatigue. And that has been a hit. We had a firefighter here in Huntington commit suicide on October 3rd of 2018. And I can't say it was because of what he saw, but I can't say it wasn't. He talked a lot about going on the overdose death of one of his classmates. And we don't know the reason why he took his own life, but we do know that nationwide, more police officers and firefighters are committing suicide than are dying in the line of duty. And I wouldn't be surprised if that's similar in the healthcare system in general. So we're trying to teach mindfulness, trying to provide outlets, more counseling, trying to make it mainstream. I have a dream that when a firefighter, police officer, or EMS worker goes to their doctor, mental health is just part of it. It's just like your regular physical, that it's no big deal. So we all need a little lift up every now and then. Cabell County's plateau was 2017. I mentioned that to you. We had 1,831 overdoses. We had 184 overdose deaths. So at the end of 2017, we started seeing a decline, which was wonderful. And I think that was probably mainly because of the quick response team, PROACT, and other things that we were doing. So we had a 40% reduction between 2017 and 2018. And I don't know of any other area of the country that has had such a big drop in overdoses. Now, the overdose deaths were not down as much as the overdoses themselves, but we felt like we had turned the corner. In 2018 or 2019, it was reduced another 19% over the previous year. So we totally felt like we were moving in the right direction. And then all of a sudden we had COVID. So COVID, isolation, loss of jobs, had people eviction. A lot of people in and that are suffering from substance use disorder, that are in long-term recovery. The only work they can get because they have felonies or in the fast food industry. So a lot of jobs were lost, and then they were evicted. It took us a while before we could get quick response team back out on the streets visiting people because of PPE restraints and issues. So we did go on a lot of relapses. We also went on a lot of elderly deaths. And I think they were people that were afraid to go to the emergency room because of COVID, or afraid to go get their medication filled because of COVID and things like that. So our overdoses in 2020 went up another 12%, but we're still on the good. Okay, we have quick response team out there working it hard. I saw on the news today that we have surpassed a milestone, in a horrible milestone in this country. In 2020, this year 21, we are already over 100,000 overdose deaths for this country, and that's sad. I feel like in Cabell County and in Huntington, we're going in the right direction. But you know what? We set our egos aside and we started working together. I filled phone calls in the middle of the night, patching people together, organizations together. And that's what it takes. It takes us all working together to make this work. You know, partnerships and collaborations are necessary to not only overcome the opioid epidemic, but to overcome any pandemic or medical issue that we have. And partnerships and collaborations create an infrastructure, you know, that can be used for any unforeseen crisis. So I think it's imperative that we continue this. I think we're morally and ethically obligated to do this, and I look forward to seeing what you all can do, because I'm a worn out old lady. Lastly, my last slide here, I have information for you. Those are links that you know, you can use. Well, I put Connie Pretty. She's the coordinator of the quick response team. If you would ever want to contact her and get more information or stats, or me, you know, it might take me a while to get back to you, but I certainly will. The bottom link, Building the City of Solutions Evaluation, it's a very good read, and it makes some unique discoveries about how we have worked together here in Huntington, and I hope that other people are able to recreate what we have here, you know, because it's going to probably take 50 years to normalize after all of this. I also want to recommend, if you haven't started watching, well, two things I will recommend. If you ever have the chance as a medical student or in residency to do a ride along with an ambulance service or a fire department, please do. Seeing how your patients that you're going to be treating live is another part of understanding where they're coming from and meeting them where they are, because we see some very, very sad things, and more than 50% of the time children are involved, and they too will be your patients someday if they aren't already. And the other thing I would recommend to you is watch the document or the series on Hulu, Dope Sick. It's 8 episodes, and it's eye-opening. To me, it's been the most realistic I've seen that the general public can actually stomach. The only thing I would add to it would be a smell for each scene, because, you know, as you all have learned, medicine does not smell good.
Thank you so much, Chief Rader. Does anyone have any questions about Chief Rader's work? I know one question that I had for you, Chief Rader, was, I guess for the QRT, that to me is a really fascinating program. I'm not too familiar with hearing programs that really meet patients out immediately. I know in the inpatient setting, whenever we have discharged patients from our inpatient service, we try to follow up within a week or within 2 weeks. But to do so kind of with patients after an overdose within like 2 days or so, that really is a remarkable kind of boots to the ground approach to keeping our patients safe. What type of response have you received from those individuals about how the QRT program has helped them, especially now with COVID, with ideas of PPE access and isolation and kind of this fear to be out in the public?
Right. I think the wonderful, it has saved many lives. About 30% of them end up going into long-term recovery, but they stay in touch with them, and they text them and they call them and keep checking on them. But they build a rapport with people and a trust that they haven't had. And I think that's vital and key, because when somebody is ready to get the help that they need, that's where they're going to reach out to, whether it's a quick response team. And that's what's so wonderful about harm reduction programs in general. There's a trust that's built there. And I think that is key. It has been replicated throughout the state, and I hope that it's replicated throughout the country.
Yeah, thank you so much.
You're very welcome.
Any other questions? I know Chief Rader, being as busy as she is, she has another, I think, meeting this evening. So again, thank you so much for your time, Chief Rader.
You're very welcome, and you all remember me when I'm old and gray and I need medical care. Okay, take good care of me, and I probably will be rotten, just so you know.
Thanks so much. All righty then. So Sarah Berzinji will be presenting our next presenter for the evening.
All right, I am honored to introduce our next speaker, Ms. Kelli Caseman, who has served as a personal role model to me for her advocacy. Ms. Caseman is both the executive director and a founding member of Think Kids, a West Virginia nonprofit dedicated to investigating kids' health issues and policy. She began working in the nonprofit sector in 1999, advocating for public education and then for kids' health issues since 2004. Most recently, she has served as executive director of West Virginia School-Based Health Assembly and as the director of the Child Health for West Virginians for Affordable Health Care. She's a fellow of the Robert Wood Johnson Foundation's Interdisciplinary Research Leaders Program, studying the linkages between healthcare and public education in rural West Virginia. And Ms. Caseman is just a vocal advocate for kids' health in our state and can be heard and read frequently all over statewide media. In 2019, she received a West Virginia chapter for the American Academy of Pediatrics Friend of Children Advocacy Award. She presents on the national and state level to a variety of organizations about healthcare needs of West Virginia's kids. And most recently, she was named a 2021 West Virginia Wonder Woman. We are so grateful and honored to have you here with us tonight, Kelli, to represent the important but often overlooked portion of our state population, our kiddos.
Thank you so much, Sarah. I really appreciate that. And thanks for having me. And I see a number of names that are familiar. So hello to everyone that I know, and it's nice to meet everyone that I do not. And I'm going to share my screen and get started. Can you see my slides? Okay, great. Thank you. So I'm going to tell you a little bit about Think Kids. We are a statewide 501c3 nonprofit organization. And we did start in January 2020, which was not the smartest time to start a nonprofit right before the pandemic. But we're still here, so that is good. And we did do some good work around COVID and kids, which is really important, especially now since the vaccine is out for 5 and 11-year-olds. But we are focused squarely on West Virginia's kids. So we try and focus on community to statewide issues of policy affecting children from birth to around 18 years old, sometimes 25. And we encourage you to take a look at our website if you'd like to know the number of programs that we're currently working on. I'll talk a bit about this more later, but one of our focuses is kids and the opioid crisis, which I call it the opioid epidemic because that's still what everybody else calls it, but it's really wider drug crisis because we're now talking about fentanyl, meth, and heroin, of course. And we have a tendency to not think of how it affects children. We really kind of focus on the adults, overdoses, and there's been, we call it a ripple effect, but it's really much more of a seismic tsunami effect of how it has affected children in the systems who serve them, that serve them. So we're talking public ed, healthcare, of course, child welfare, foster care, the court system, and of course, community services. And so we try and elevate and articulate those needs on the both county and state levels. We've done a lot of work around COVID-19, and I'm going to talk more about this in a little bit about the kind of surge of misinformation that has really made advocacy harder. And COVID-19 is really a prime example of that. And so we've tried really hard to spread accurate data as the pandemic has unfolded. The project that I work most closely with Sarah on is the Including All Kids project, where we're working to transform the healthcare system for children with special healthcare needs in West Virginia. And this is a really important project because one of the things that we don't do in our state is collect data, which I'll talk about in a minute, but it makes it really hard for special populations, marginalized groups, so people of color, people with developmental or intellectual disabilities, to meaningfully access healthcare. And it's a complex conversation to have with legislators, and it takes more than just one conversation, right? It takes a united effort. And so we're really embarking, this is year one. We've been funded for a second year, Sarah, so we'll be at this next year, which is wonderful, yes. And we will be talking with a couple of legislators this year, but we really want to have a strategic approach to implementing those necessary changes. And then the Health and Hunger Project is a project where we're looking at food insecurity around the state of West Virginia, and we call it the food resource infrastructure. So how food from the national level makes it to the state level. We have 2 food banks in our state, but then how does it get to those communities? And that's where it becomes very tricky because we don't have kind of this pipeline. We have a number of people living in very rural places in the state where they don't have transportation. And so, as you know, it affects their healthcare, and we have the healthcare system that doesn't really know where these resources are. And so we're trying to build bridges between those systems. A lot of the work that we do, particularly around the pandemic, is on social media. And so I think that if you're interested in doing more advocacy work, I can't say this enough, get on Twitter. I bet Dr. Costello has said that to you a few times as well. And it's not just to keep abreast of issues, but it's a great place, at least for me, to find academics who are working on publishing emerging data that can be very useful to the work that I do, because, you know, data informed advocacy is really so important. If you think of advocacy, you should think of it as a spectrum. Okay, so one side is pure objective policy, and then one side is pure activism. So these are the folks who occupy, you know, a senator's office space, and this is a person who may be doing research with no agenda at all, trying to look at an issue. And if you want a movement to move a policy forward, to move, you know, an issue forward, it takes everyone along that spectrum. And if you're interested in doing advocacy, I would, you know, really kind of reflect on where it is you want to be on that spectrum, and, you know, find your voice along there. And so you will find those folks, you'll find a lot of stuff that you don't want to find on Twitter. You find a lot of people arguing, and it's not conducive to pushing any issue. It can be really kind of, you know, it's not civil, I should say. But in there, you will also find members of academia, you'll find researchers, you'll find a number of people who are doing really important work. And so we are on Twitter a lot. We have a Facebook page as well, and we're pretty active there. We have a YouTube channel, and we publish videos pretty regularly looking at issues that are of interest to people around the state. Then we try and bring, Jan said, bringing, community is really important. So we try and bring people from different systems and communities around the state to talk about particular issues. And then an important thing that we do is we hired this year a kids health correspondent, and her name is Erin Beck, and she used to write for the Gazette and a couple other newspapers in the state. But importantly, she has a master's in public health. And so she can tackle an issue, with more depth and with nuances and the complexity. And she just sent me something. So you'll see something on foster care go up tomorrow on our blog. And so we really think that it's important to be active on social media and to ensure that we're trying to share honest, objective information to get out into public consumption. And it's gotten, especially on Facebook, well, I'll talk about it in a minute, the kind of public health used to be much more of an objective, people had more reference or revered it. And now there's this real undermining of public health. And it's really hard to try and explain science and data and information to build public trust. And that's something I think that as you move forward in your careers, you're going to have to tackle that generations before you did not. And so we started Think Kids in January of 2020 after my first year in the Robert Wood Johnson Interdisciplinary Research Leaders Program. At the time, I was the Director of Child Health for West Virginians for Affordable Health Care. And it was, and it is a policy and advocacy organization in West Virginia that really focuses on advancing comprehensive health care for everyone. And it's a great organization. But what I really wanted to focus on after I had been part of this project, this fellowship, and we did all this, professional development and meeting people around the country, is I really saw a gap in advocacy in the state of West Virginia and how we were trying to advance good policy work forward or trying to inform the public. And I felt as if, particularly when we talk about kids, that I felt as if personally I wasn't getting anywhere with the legislators because I was coming at it from the heart, because you want to do good things for kids because it's the right thing to do. But it's really important to also say it is the smart thing to do. And it's, better for us. And here is why. And here's how it's, economically and doing things efficiently. And I thought, we're missing this, and I will be better at what I'm trying to do if I try and focus on my work in this way. And so to me, if I were to categorize the state of advocacy in West Virginia, I would say these things. One is we lack comprehensive data. So if you started getting on Twitter right now and you became more of a follower of it, you would see that a lot of people have opinions on things without actually having kind of a data foundation, right? And this is especially true in West Virginia, and it's actually very true sometimes with our legislators. But if you're reading Twitter and you see studies coming out of other places, or you see stats of like children in Rhode Island, think to yourself, I wonder if we have that data in West Virginia, and try pulling on that thread a little bit and see if we have that data here. So it's not that we just don't have the data. Sometimes we have the data because we're obliged to report it to the federal government, but for some reason, we're not making it like there's no dissemination strategy. Like here's our rate of children in Medicaid who have had their well child exam. That's important information, because if we don't have kids who are going to the doctor for their comprehensive health care at least once a year in the Medicaid population, which is, kids who mostly are living in poverty, there are a myriad of problems with that, and we should be tackling it. But if people don't know that, they're not going to advocate for it. They're not going to coalesce as a community and say, what can we do together? So we don't have a dissemination plan. And then we often have a lack of appetite by government or institutions or policymakers to value, share, or use data to inform policy decisions. And so we've heard about syringe exchange programs, for example, today, and the need for them. Well, I'm sure that you saw during this legislative session that there was a real change. And, you know, the restrictions have been made so hard, like in Mercer County, for example, they're closing theirs. So that was a debate that really wasn't fought on the level of evidence-based policy. Is this a good idea or isn't it? And because we were not, you know, kind of public health was not really prepared to make that argument, it became something very political. And, you know, and we really kind of walked backwards at a time when we really can't afford to walk backwards when you just heard about the spread of HIV and overdose deaths. And so, you know, it's really important that we have an informed population in West Virginia who know what the facts are and are willing to fight for them. So if you're interested in doing more advocacy, here are some suggestions. Like I said before, tuning in is very important. Check your data sources and ask, is this data that we're collecting here in West Virginia? And if not, why not? So the project Sarah and I are working on together, that data is just not there. We don't know how many children in West Virginia have developmental disabilities. We don't know if they're accessing healthcare. One of the people we're working with on this project emailed me a couple of days ago, and she said, do you know our rates of children with developmental disabilities who have been vaccinated in West Virginia? We have no idea. So we really have to look at what data we're missing and then asking, what is it we can do to get that data? I think it's really important that we get better at listening to one another. There's a whole lot of yelling right now and not a lot of listening. We have really kind of politicized issues, particularly kids, right? So kids don't have a dog in the hunt, and yet we keep talking about things going on in the schools, right? Everything is about public education right now, and almost none of it is coming from a child's perspective. We had a student, a high school student, who wrote a blog post for us about how she felt about, you know, getting vaccinated and mask mandates in her school. And we really had to police our Facebook page because people were posting things. And I thought, you know, I never really thought people would post something against a teenager, but they did. You know, we're just living in kind of these hard times. So it's important that we try and remain civil and listen to one another. Trust your voice. So I say this because, you know, years ago, when I was in graduate school, both of my degrees are in English, and I went to West Virginia University. And when I taught freshman composition, I had so many students who didn't want to, they thought once they graduated, what they had to say would have more importance, right? Once they had that degree. I hope you're not feeling that way right now. And if you do, what we really need you right now, we need you to share your voices, share the knowledge that you have right now, and trust, you know, your own convictions to put them out there. We need voices of reason. We need people who trust research and data. Collaborate just like you're doing right now. If you find somebody who shares a joint issue with you, work together. If you want to write a blog post for Think Kids, we will certainly put it up. If you want to try and get something published in the Charleston Gazette, we'll help you with that as well. And then learn the process. So know when legislative session is, which I believe it starts January 9th this year. It's going to last 60 days. Right now is that time when our legislators are starting to kind of try on ideas that they plan on pitching during legislative session. So read your state media, read the Charleston Gazette, read the Dominion Post, read West Virginia News, and see what legislators are out there kind of shopping around ideas to see if they can get some momentum going on in the state. So saying all that, I just want to go over some emerging issues. I'm sure that you all know that there's been kind of an undermining of public health over the last few years. At least I hope you do. Maybe you saw the attacks, for example, on Big Bird over the last couple of weeks, because there was a video of Big Bird going to get his COVID-19 vaccination, and some people were really upset that Sesame Street was politicizing getting your vaccination when back in the 70s, Sesame Street did an almost exact video of Big Bird getting his shots. And so it's most unfortunate. Public health has always had a bit of a political tinge. I say this because years ago I worked on clean indoor air regulations, for example, in West Virginia. And the people who fought against clean indoor air regulations were, the big tobacco companies. And the big tobacco companies, used to be the largest funders of Republicans. And so you had a tendency for more Republicans to be against clean indoor air regulations. But at that time, you really didn't have political parties that kind of worked in tandem so closely. Like, everything is so polarized right now. So it's really hard, once a political party kind of owns an issue, to find a legislator in that party who's willing to go against the party. And so there's, a bit of an undermining, there's definite undermining in public health. And I really hope over the next couple of years, we can try and do some more PR around trusting the voices of healthcare, because that is really important, especially in West Virginia. And so because of that distrust, and let me see if I'll be talking about preemption in a minute. I have a real concern that our school health policies in West Virginia are going to be challenged during legislative session, which would be a terrible consequence to us. We have some of the strongest school vaccination policies in the country. I have been around for a long time, and I don't remember how that happened, because we normally don't have such, it's us in Mississippi. It's strange but true, and now California, I believe. But there have been outbreaks of the measles, but this with COVID, we've had such a undermining of and misinformation around vaccinations about what's in them, and so I'm really concerned. If you're really pro-vaccine, especially for children, I hope you'll help work with us. West Virginia Immunization Network is the group to reach out to, in ensuring that we can save those immunization laws over the next year. And preemption is another concern. So preemption, in a nutshell, is when public health, like say a local health department, has to get permission from like a county commission in order to pass a public health law. And clean indoor air regulations are a great example of a consequence if these preemption bills pass, where perhaps a county is considering that it would make more money if you brought back smoking in bars, for example. And they may start challenging these laws, and we go county by county, and that would be really hard for advocates to go from all these counties to try and fight to maintain those laws. And so preemption is something to really look for. It's not just happening in West Virginia, as you see from this little snippet. It's happening all over the country. And so we really need to fight for our public health experts in West Virginia. I pulled this from the Washington Post today, that as Jan Rader had said earlier, we have seen an increased rate of overdoses during the pandemic this year. West Virginia is number one. As you see, we're the only one in blue. We're by far have the highest rate of overdose deaths during 2021. And if you read the article, the age demographic with the highest rates is the ages between 21 and 25, which is childbearing years. So think moms, dads, aunts, uncles, older brothers and sisters. It's really something that has been hitting home with our children, and we really lack a robust network of mental health care providers in the state. And so this is something that we'll be focusing on in legislative session. And of course, the poverty is always creates a myriad of healthcare disparities for kids in West Virginia. And so I don't know if we'll be seeing any discussion around those issues during legislative session, but I hope that we get better at working with other advocates around the state to, eventually, once, Think Kids is around for a couple more years, we have a slate of issues, that we have enough capital pool that during session we can say, here are the issues that we want to cover. And I hope if you were interested, you would share your voice as to what you would like to see us take up at the legislature. And that's the end of my slide. So it's open to any questions you may have.
I had a question. Thank you, Ms. Caseman, for an excellent presentation. The question I had was about we talked a lot about the collection of data, the importance of collecting data. And then I think another aspect that I think we're seeing a lot, especially now with COVID, when it comes to the vaccination efforts, is making data digestible for different audiences. I think from a vaccine perspective, the things that I've seen in clinic and in the hospital, talking to my patients about the importance of being vaccinated is I'm competing against Facebook. I'm competing against kind of the bright lights and the flavor of, if you will, of Facebook. And then if I present them with data that, is comparatively bland to what they see kind of on social media, whether they get on the streams. And from your experiences, what are ways that we can make this data, then the facts, really more palatable for patients to make these informed decisions?
That is a great question and point. So what we've been doing at Think Kids, I mentioned before Erin Beck, who was our kids health correspondent. She and I talked about the fact that we can be very dry and very, you're right, kind of data heavy, and it doesn't it doesn't resonate with people as well as, kind of the things that they see on Facebook that can be kind of, as you said, kind of bright and shiny and bells and whistles. And she actually started digging around to find data of children who were in ICUs and were on ventilators and the ages of them, because information doesn't travel very quickly, or it stays too long when it comes to COVID. And so during the beginning of the year of COVID, we kept saying the kids weren't as affected as adults, but then the Delta variant, we saw, it was different, and we didn't really resonate. We didn't hit that information hard enough, I don't think. And so now people just assume that kids don't get as sick, and that's what I see on Twitter all the time, and I see that as the Facebook messages that we get on our end, and I think that explaining the fact that, and I know you don't have all the time to do this, but to share the statistics, I think that the number that Erin dug up was around 40 babies were hospitalized with COVID. Resonates with people because that's, clearly it can be severe cases. So it's, and I think that we can also say that, we have had a really high bar of vaccination policies in this state, and we expect children to get vaccinated. And so what is it about this vaccination that you think is so different? I had a provider say to me that she said to one of her patients, if I really wanted to put that chip in you, I could have put it in you like all these times over the past many years. Why would this now be the moment that I would be chipping you? Which you probably wouldn't want to say that to a parent. But, I think that we have to be a little bit harder hitting. I think that in public health, we have this tendency to want to be very respectful and timid. And now is the time we have to be a little bit brasser about the fact that, you know, kids need vaccinated. If we really want COVID to recede, they have to be vaccinated. Kids deserve to be back in school and be kids and develop and socialize. And we're taking that away from them when we're making it about our politics. So I don't know if that helps you at all. And I hope that you all on your end are having these conversations and could share with us what works, what you find resonating with parents, because it's something that we're certainly going to be turning the heat on, especially around legislative session, because this backlash against vaccinating is really concerning to us.
Thank you so much. And I think Dr. Costello has a comment also in the chat. Yeah, like Dr. Costello was saying, it is a fine line. It is a very delicate balance. And, you know, the difficult thing is, you know, there's no guidebook to say, you know, how to approach these things. A lot of it is just nuance. It's understanding how the parents are, and that's really where rapport comes into play. And I think that's really where we have, as providers, have to really rely on our prior experiences with those parents and with those patients, to have those conversations, to understand what it is that that can really reach them, because it's, you know, it's not a cookie cutter approach. So thank you again, Ms. Caseman.
Can I make one more point? I think that in West Virginia, we have a silent majority of people who support vaccinations. The importance is to rally and get them working collectively. You know, people don't really want to have to keep putting their dukes up to fight for something, but they really need to know that they may lose like their policy if they don't kind of stand up and be heard. But again, civility is key, I think. Always, you know, trying to keep things from spiraling out of control, because we live in such a politicized moment.
For those interested in finding more information, there's a social media press kit. I think it might be, yeah, the social press kit. Thank you, Dr. Costello, for putting in the link there. And I'll actually, after this meeting, I'll be sending out the PowerPoint slides and sending out this link as well to everyone who's RSVP'd. Now, moving on, our final presenter of the evening is Dr. Joanna Bailey. Dr. Bailey is a graduate of WVU School of Medicine, where she also completed a family medicine residency and is today a physician for the Tug River Health Association, serving patients in McDowell and Wyoming counties in West Virginia. In addition, Dr. Bailey focuses on the issues of obesity medicine and limited healthcare access in rural populations. Dr. Bailey is also the past president of the West Virginia Academy of Family Physicians, and for her work, Dr. Bailey was recognized by WV Living magazine as a 2020 West Virginia Wonder Woman. So, and I've personally had the immense privilege to train under Dr. Bailey last year and again this year. And I'm very inspired by Dr. Bailey's dedication to her community and her practical, holistic approach to medicine. All these conversations we've been having this evening about the importance of building rapport with those patients, I think Dr. Bailey is a fantastic physician who really embodies those humanistic values that we need to have in medicine. And I do fully believe that every medical student, you know, if I had my way, every medical student in the state would be required to rotate with Dr. Bailey. And I think after hearing her presentation, I'm sure you will agree as well. So Dr. Bailey, it's all of you.
Thank you so much, Emma. Can you guys hear me okay? And do I have an echo?
No, audio sounds good.
Okay. Okay, good. Can you still hear me? Okay, awesome. I was just transitioning from headphones to computer because I don't know how to do it otherwise. So welcome to my laundry room. I had a lovely place picked out in the kitchen, but now my little boy is having a blast in the living room, which is right next door. And so it's been quite noisy in there. So I decided to hang out with you guys in the laundry room. So thank you, COVID, for teaching us how to do these sorts of things, right? And I just want to start by saying that you guys have done a stellar job. I'm really glad that I got on at 6 and got to listen to the other talks because they were really incredibly inspiring. And I will say to the medical students who have introduced everybody and to Emmett, you guys are like rocking it. Those were some truly professional introductions, and feel free to contact your lawmakers with those voices because you're doing a great job. So Emmett, I'm going to try to share my screen. I have 50,000 tabs open as usual, so let's hope it goes well.
All right. And if you have any difficulties, you can, or I think it's loading up now.
Okay, good. I'm gonna try to make it a presentation for you. This PowerPoint's gonna be really ugly because I didn't format it. I'm gonna embarrass. Oh, my presentation button is behind my Zoom buttons. Here we go. There we go. Okay. So, my talk is going to be quite a bit different. Mine is going to be more related to direct patient care. I'm going to take you through a patient case, and we're going to talk a little bit about advocacy at the point of care. So mostly we're going to focus on Medicare. I'm still hearing myself talk. Can you guys hear me?
Yes, we can.
Okay, good. Realize my phone is still connected. So first off, I actually want to just spout some random pearls at you. You will know if you rotate with me that sometimes I just throw random information at you. And so that's what's happening here. These are actually things that were coming to mind as I was listening to the others. First of all, know your people. So on a state level, the state is very, very small. It's totally possible to know everybody that does things in healthcare at a state level, okay? If you want to be involved, know them, get to know them, and you will over time if you are just involved. Know your legislators, your legislators in Morgantown and Charleston and probably out in Martinsburg as well. A little bit of a bigger population, so it may be harder to get to know your lawmakers from your particular area because they're representing more people. But it never hurts to email and introduce yourself. It never hurts to show up in their office one day and introduce yourself. Then they love those things. They love meeting their constituents, especially the ones that have something to say. And it doesn't necessarily matter if you voted for them or if you agree with them on everything. They're happy to talk to you just as someone who they're representing. Most of them are there because they have pretty good people skills and they like to talk, most of them. And knowing your people is important. And I will give a plug to rural health here because, like I said, it's a lot easier in a small town. We heard reference several times that bill that unfortunately passed and basically put huge barriers to doing harm reduction clinic in the state. And it was, I literally had one of our senators who's on Senate Health text me the day that bill was being voted on and say yes or no. And I said, no, and he voted no, but it didn't matter. That he asked me and he asked his son, and that was as far as it went. And then literally 2 weeks later, after the bill had passed, another lawmaker walked into my office one day and said, hey, do you have a few minutes to talk about the harm reduction stuff? I want to see if there's any way that we can get around it. So know your people and they will use you. They'll use you as a medical resource. You'll be called upon to testify in front of committees, things like that. And don't be afraid just to send blind emails. The Opioid Reduction Act has been a wolf in sheep's clothing as far as primary care is concerned. And the AAFP or the WVAFP really argued against it whenever it was first coming about. But it happened anyway, and now we're seeing some true harms of it. I have a patient that lives deep in McDowell County, and I really feel that patient is going to see harm from it. And so I did not hesitate. I sent an email to the whole joint health block, and I got like 6 or 7 emails back. So hopefully something will come of that. And I didn't do that as a representative of anybody other than myself. So know your organizations and support them. Don't argue, keep asking questions. Same thing with the vaccine, keep asking questions. What's your logic behind that? Eventually people who are making silly decisions will talk themselves into a corner. And if you can't give, or if you can't do, give. And if you can do. Even if you can give, do, because we need more doers in the world. As a doer, we need help, okay? So, but at the same time, remember your limitations, because everybody's searching for balance. And honestly, I think balance is a misogynistic myth, because there's really, in the end of the day, only 24 hours in a day. And you actually are a student, a doctor, a mother, a son, a wife, a daughter, a husband. You're all these different things all at the same time. Part of your life doesn't end when you walk into the office, and another part start whenever you get home. I take my home life to work every day. I bring my work life home every day. And I try to make sure that I'm putting drops in all of my buckets on a regular basis. And that's really important whenever it comes to advocacy, because sometimes you feel like it's this fight is worth it. This fight is worth staying up 4 hours tonight to write this op-ed. And maybe it is and maybe it's not, but you have to evaluate yourself and know what you can do and what you can't do, and you need to be realistic about it. But if you can do it, but know that as you're doing that, where are you not doing other things, and make sure that you're having conversations that need to be had with the people in your lives. Okay, so getting on to the thing that I actually wanted to talk to you about, Medicare Part D. And this is going to seem kind of specific, and it is kind of specific, but it's probably the area of my work that causes me the greatest frustration. And I find myself advocating at the point of care more than anything else. So what is Medicare Part D? Medicare Part D is the voluntary prescription drug program that is part of the Medicare program. So I didn't look up the history for this, but when Medicare was first invented and created, it did not have any prescription drug coverage. And so several years later, I think under George W. Bush, they created Part D. And what Part D is, it's optional. Patients have to buy into it. And often they will buy into it in such a way that it's just deducted automatically from their Social Security. But they do have to pay a premium on it. Usually it's taken out of their Social Security monthly. And that's usually somewhere between $45 and $150. And then each formulary has its own, so each different Part D plan, which are ran by private insurance companies, have their own formularies, and they have their own pharmacy benefits managers, which is a whole separate talk, that manage those formularies for them. And so you may have a patient who has been on this one, and then they change and their formulary is totally different, or they've been on this one and the formulary changes and everything is totally different. And it's very frustrating. So the medications that are covered within those drug plans have different tiers. And I think I have a slide about that in a minute. There's also something called Medicare Advantage plans, or Medicare Part C. I didn't talk about Medicare Part A and B, but A and B are like physician services and hospital services. And Medicare Advantage plans put A and B with Part D. And basically it provides it's a private company that provides you your Medicare services. And there's some advantages, in my opinion, and I'm speaking for myself only, the advantages are mostly to the rich people at the top of those companies, and not to the patients. But the advantages to the patients are that they can sometimes get like vision and dental coverage, but they don't have any better drug plans. And they don't cover things such as long-term rehabilitation stays and things like that, as well as just straight Medicare. So I always encourage patients and family members to just use straight Medicare, not any of the Advantage plans. All right. So this slide's a little bit tongue-in-cheek. This was at the end of a different talk that I gave, but I left the tongue-in-cheek in there just for your amusement. Medicare Part D must stand for doctorate, because that's what you have to begin to understand it. Is the bar open yet? You guys probably don't have a bar, but the conference I was giving this at did. So when it comes to prescription drug coverage, Medicare Part D has 3 official parts, but really there's 4 parts to it. There's the part when the patient hasn't met their deductible yet, and the deductible is usually about $450. Supposedly there are some unicorns out there that have $0 deductibles, but I've yet to see one. There's the second part, which is when the co-pays are happening, people's making their copay. And then the third part is in the donut hole or in the coverage gap, and we'll get there in a second. And then the fourth part is you're on the other side of the donut hole or the other side of the coverage gap. So I remember very specifically that I was a second-year medical student whenever I learned of the coverage gap. And I was like, what the heck? Why is this a thing? This doesn't make any sense. And then I remembered it, and I saw patients have those issues. And then the Affordable Care Act was passed in 2013, and I got really excited because part of that was closing the coverage gap, or closing the donut hole. And we'll get to how the donut hole closed mythically in a minute. So let's stop here at copays for a second. So patients' medications are covered under their insurance plan, but they still have to make copays on those medicines. So copay is the portion of the medication cost that the patient pays. So patients have, there's kind of there's 5 different tiers of medications. And I think I go through that in a minute, but basically you've got most patients' medicines are going to fall into either preferred generic medications or preferred brand medications. Preferred generics are usually very cheap, about $3 a month. Preferred brand is more expensive, $40 plus a month. And then you've got your coverage gap. So the coverage gap is a wonderfully brilliant thing. I don't know who thought of this. They need some sort of prize. But it begins when the total cost of the drugs reaches $4,000, $4,130. That's for 2013. It changes every year, or 2021. And they stay in it until until they reach $6,550 of total cost. And so used to, before we closed the donut hole, the patient would have to pay 100% of their drug cost at that point. And so it was really common back in 2013 when I was in residency for patients in the fall to start falling in the donut hole. So like September, October, they would fall in the donut hole and they couldn't get their insulin anymore because now their insulin was going to be $1,000. And they would have to pay like $2,500 worth of insulin in order to get out of the donut hole before Medicare would start paying for their medicine again. Well, in 2013, the Affordable Care Act was passed, and it said in 2019, I think, the coverage gap will close. But what they meant was that the coverage gap would be reduced, and now the patient would only have to pay 25% of the cost of the medicine. But turns out 25% of a medication that costs $1,300 a month is still a lot of money, especially if you're on a quite limited income. So even though they closed the donut hole, it actually hasn't had any practical benefit, at least to my patients. And now as drug costs have continued to skyrocket, my patients are following in the donut hole in like March or April. they're not even waiting until the fall. The thing about going in the donut hole in the fall is that you get out in January. It starts over, new coverage year. But if you fall in the donut hole in April, you can't wait that out, right? Like you can't ration your insulin or whatever expensive drug you're on to last you from April to January. It's not realistic. You've got to come up with a different plan. So let's see, premiums are down here. It's been a long time since I made that slide. So let's talk, oh, I didn't talk about tiers in my computer sign. All right, we're gonna take a 30-second break. If you haven't stood up for a little while, stand up, move around. I'm gonna grab my computer cord so this show can keep running. Have my computer cord already in the kitchen in my original spot. All right, so I'm gonna tell you guys briefly about tiers because I either lost that slide or I didn't put it in here like I thought I did. But tiers are insurance lingo for how much they don't want to pay for a medicine. So tier 1 is medicines that they don't really mind paying for. They get them pretty cheap. And so they're gonna, that's preferred generics. They're gonna give that to the patient for a few dollars each month. Tier number 2 is generics that are more expensive. They do not like to pay for those, but there's not very many drugs in there. You're probably not really gonna encounter them. Tier 3 is preferred brand. Those are brand drugs that the insurance company has negotiated a lower rate for, except that Medicare Part D, Medicare is not allowed to negotiate for lower rates on medications. Thank you, federal government. So there's another hill that you guys can climb and fix, please. And then tier 4 is non-preferred brand name drugs. Nobody can get those. And tier 5 is specialty medications, and I've never had to deal with those, so I can't tell you too much about those, except maybe hepatitis C is specialty. But anyway, so let's get into our case study a little bit. So this is a patient, we're going to call her CC. She's a 69-year-old female, and she has a pretty typical past medical history for somebody in McDowell County. She has a history of hypertension, diabetes, hyperlipidemia, stage 3 CKD, anxiety, gastritis, vertigo, overactive bladder, chronic low back pain. She's got a BMI of 36. She's got diabetic neuropathy and diagnosed vitamin D deficiency. She is on more medication than she should be. She's on less medication than she was when I inherited her, but still more than she should be. Got some polypharmacy that still needs to be addressed here, but you can see her list of medications there. The ones that I'll draw your attention to are the insulins down here. She's on insulin degludec or Tracebo, 90 units a day, and insulin aspart, which she takes per sliding scale, which she is married to and not going to change, at 60 units a day. She was previously on a sulfonylurea and was getting hypoglycemia with that, so we stopped that one. Her labs, as you can see, she's got an A1C of 10. I think her A1C before we stopped the sulfonylurea was like 9.2 or something, so it was a little bit better, but that little bit better probably represented her random glucoses of 40 and 50 rather than actually an improvement in her glycemic control overall. Her glucose is usually high. Creatinines 1.44, triglycerides and HDL show us that she's got some metabolic stuff going on, which we already knew. So a little bit more about her and her social history. She lives with her husband. They have a combined income of $36,000 a year. And that is just based on both of their social securities. Neither of them have any type of outside retirement, and they don't have any other income. They're both retired. They don't have a mortgage. Thankfully, they've paid off their home. They do have a $700 a month car payment, and the energy bills for the trailer that they live in is quite high. They pay as much as $400 or more in the wintertime to heat their home. They have a lot of bills. And I usually whenever a patient tells me that they have a lot of bills, it means that they have a lot of medical bills that they're paying on, or it may mean that they have outstanding credit that they're paying on, such as credit cards, you know, purchases on credit, things like that. And I think it's easy to judge people based on this idea of having a lot of credit card debt, making poor decisions, but a lot of that, you know, comes over time. If you are living paycheck to paycheck and your car breaks down and you have to have your car to get to work, and you have a credit, and your only choice is to put whatever car part on the credit card, then, you know, it happens. And sometimes it's hard to get those things paid off or paid down if you're only making the minimum payment and you can't do better. So anyway, they struggling to get ahead because of a lot of bills, and they're on their limited Social Security income, but, you know, a fairly reasonable income for Southern West Virginia. You would think with $36,000 that they would be able to afford most of the things that they need. They do also provide partial support for several of their grandchildren. This is incredibly common. 85% of grandparents in Wyoming County, where I work primarily, are providing at least partial support to their grandchildren. So not uncommon at all. You should be better off to assume that people are doing it than they're not. I went on Medicare.gov and I plugged in all of CC's medications, and this is her total yearly drug costs. So this number includes her premiums and her medication copay costs, things like that. We'll break it down a little more in a little while. So basically it comes up to almost $6,000. So she is expected to pay roughly 20% of her yearly income in drug costs under Medicare. Of note, her husband is of similar health. He's not my patient, so I don't know what all he's on, but they've told me multiple times that he has diabetes too, and they pay a lot of for his medicines as well. So you know, it's possible that combined they're paying over $10,000 a year just to get the medications that they need to survive. Again, my poor slide formatting, but this is a lovely thing that Medicare.gov does for you. It breaks down your monthly medication costs. And I don't understand this at all. Usually when I do this for a patient, it becomes clear to me when they fall in the donut hole and when they get out of the donut hole. But this doesn't really make a whole lot of sense because she's got a lower cost at the beginning and then it goes down a little bit. If we have some time at the end, we'll look at some other reports that I did for family members and see if we can find one that is a little better of an illustration. But we looked at, so that was for her current. So this is for her current medication regimen on her insulins. Okay, so I'm going to go back a couple more slides, maybe. I don't clicking the wrong thing. And Emmett can tell you I like to pimp the student. So what do you guys think? Answer in the comments. What do you guys think about her current diabetes regimen there? I don't know if I can see the comments. Will somebody read them for me? Because I don't know how to get them. I'm screen sharing. Oh, there they are. Hold on. Figured it out. I hope you can hear my son singing in the background. Insulin management can be adjusted. It could be adjusted. Yep. What do you guys think about the amount of insulin that she's taking? It's a pretty whopping dose. She's taken like 150 units of insulin a day, right? So whenever, this is actually 30 units more a day than she was taking 6 months ago. She, her A1C was 10, and you know, I started talking to her about some things that we could try. So I'm going to skip back forward here. You guys feel free to throw up comments now that I've found the chat. I'm hoping that you guys have seen this at some point in life. This, I believe, is the ADA diabetes guidelines. It's either Endocrine Society or ADA. And then this one is the other one. And so what do you guys see that this patient is not on these diabetes guidelines?
There's no metformin for this patient.
Right, and that's because of her because of her CKD. We stopped that. She was on that before. But she's also not on a GLP-1 or an SGLT2. Right, and she would feasibly qualify for one because we know she has CKD. She should be on an SGLT2. They're approved for not only diabetes, but for CKD and for baseline kidney prevention in diabetics and others. And then a GLP-1, she's at pretty darn high risk for CAD and CHF. And we know that GLP-1s reduce their risk of death from cardiovascular disease. So she would be a fantastic candidate for either of those medicines, and she's got a BMI of 36. So we could expect to see some decent weight loss with those medicines for her too. So what did we do with her? Hold on, my slides are out of order. Okay, so I copied this straight from the real patient's chart. So she was previously on 30 units a day of her sliding scale insulin, her short-acting insulin. And we increased that up to 60 units a day. And show Dad. And what happened? Her A1C was 10, and then it was 10 again, and she gained 8 pounds. So she came back and she said, I'm really frustrated. I've gained weight with the insulin increase. And she was hungrier. She was having more cravings. She had noticed increased abdominal girth. And she was less likely to be sticking to a diabetic diet at that point than she was before. And the other thing that I now know that she was doing is she was rationing that insulin. So she wasn't taking it as prescribed. So she wasn't even taking 60 units a day. She was probably taking 30, 40, 50 units a day, whatever she felt that she could get by with, because she knew if she could make it last longer, that she would have to pay less at the drugstore. So she had increased it some. I don't actually know the numbers of what she was taking because she tells me that she's taking what she's taking, but according to the pharmacy fill data, she's not taking all that was prescribed. So she was rationing, she was gaining weight, and her sugar was getting no better. So I said, wouldn't it be great that if we could get you on a SGLT2 or a GLP-1? And so I sent them to the pharmacy, and the patient went to the pharmacy and they said, that'll be, $450. And she said, nope, can't do that. I can't do $450. So I said, well, shoot, I must have picked one that was not in the preferred tier. So we sent the other 2 drugs in that class, and the pharmacist ran them. Nope, those are same price. And so finally I annoy the pharmacy tech enough to finally figure out that this is the patient's deductible that we're running into. And so I'm like, crap, how do you get past the patient's deductible? You know, she's just gonna have to pay it. And so we kind of put that in our back pocket. I increased one of the insulins a little bit. And then I give it a couple months. Okay, so a couple months go down the line, her A1C is still 10. She hasn't gained any more weight. And so I say, okay, well, let's try again. So we send it to the pharmacy again. At this point, she is over her deductible, but that medication alone is going to be $150. I'm like, what the heck? And so now, oh, I picked the wrong tier, or I picked the wrong medicine. It must not be preferred. So I send in a couple more, and those won't go through either. Same thing. They're all $150. So I call Humana, which don't do it. So I call Humana. I'm on the phone with Humana, and finally I learned that actually all of her medications, all of the SGLT2s, I think is what we were trying to get, are tier 3 preferred brand, and they all have a $45 deductible or $45 copay, and she gets her medicines 3 months at a time. So adding on $150 to what she's already paying is not an option for her. So I said, okay, well, you know, what's the GLP-1? Same thing, $45, all of them in the same tier. It turns out both her insulins also in that same tier. So she's already paying $150 every 3 months for her insulins, not to mention the fact that she's on 50 other medicines that are probably preferred generic, but those $3, $5, $10 copays do add up. So what do? I get really frustrated and I write my senator. I highly encourage you to do such things. So there's the email that I frustratingly sent to Senator Manchin's office. And I titled it, Part D is killing patients and their doctors. So feel free to read that. But you know, I sent it off and I moved on with my life. I didn't have any more time to think about that patient that day, unfortunately. So a few weeks later, I get a phone call from a fellow who tells me that he is a pharmacist with Medicare. And he says, I'm reaching out because you reached out to Senator Manchin's office regarding a patient, and I wanted to see if I could help you in any way. Maybe you were just frustrated, or is this something that you actually want to pursue? And I was like, well, I was frustrated, but you know, let's pursue it. Let's do this. So he and I get to talking, and he struggled for quite a while. He and I both struggled trying to figure out why the Farxiga and the other medications were being so expensive for her. And then we figured out it was the copay, and then we figured out you know, where she was in her deductible and where she was in her donut hole. And you know, it kind of ended up with, this is just how much these medicines are going to cost for this patient. And so I said, well, she can't afford it. You know, it's not in her budget to purchase those medications. So he had a few suggestions. So the first thing he suggested was a program called Extra Help. And Extra Help, I think, is through Social Security, but basically it's for people, I'll go to the next slide already. It's for people who make between, for a married couple, less than $26,000 a year. So assuming that she qualified for Extra Help, she would be paying like almost a quarter of her annual income for medications in order for her to qualify for Extra Help. But thankfully, you know, your burial plot is not going to kick you out of getting Extra Help. So other programs, so we applied for that, she didn't qualify. And so this is kind of where we are now. Things that we're looking at now to try to get these her medicines. It's a program called West Virginia RX, which is, it's through HealthRight. I don't fully understand it. Some of you all may understand it better than I do. She's applying for that. We've also sent her, so I'm happy to say something happened because Medicare patients didn't used to be able to qualify for PAPs or patient assistance programs, which come through the drug companies themselves. And so they now apparently Medicare patients can get those. So we've identified a couple of those that she could potentially qualify for. There are samples which you have to allow drug reps into your office and interact with them and sign their papers and eat their food in order to get samples in your office. And in my opinion, it's not a sustainable way for a patient to get medications, but I totally understand the docs and the nurse practitioners and PAs who do that in order to get samples, because when your patients fall into the donut hole and they stop taking their insulin and they get admitted and they nearly die, you know, if there's something you can do to have some free insulin on hand to give those patients, then that's helpful. But again, it's not sustainable, especially if the patient's fallen in the donut hole in April. And then the patient can keep doing what she's doing, which is, you know, rationing her own medication. She could, you know, sign over some of her things that she owns to her family and try to qualify for Medicaid, but you know, those are not feasible solutions. So I think I'm over time. I will stop there. But I'm happy if you guys have a few minutes to answer any questions that you might have.
Thank you, Dr. Bailey. Does anyone have any questions for Dr. Bailey? You know, one thing is, I'm not sure how this applies for Medicare, but one thing I just wanted to give a shout out to is that their website, GoodRx. I know for some patients it is like use, and you know, it may not help every patient, but if for those who are unfamiliar with it, it's another option to try out GoodRx.
You're absolutely right. And that's so sometimes the patient can pay cash and actually get the medication cheaper than they can get it on their insurance by using a discount program like that. But again, sometimes there are programs like that that certain patients don't qualify for because of Medicare, because it's been written out of the Medicare code. So.
All right, so thank you, Dr. Bailey. And again, thank you to all of our presenters tonight. This has been a really fantastic event. We're very glad to have heard these different perspectives. I hope that these are issues that a lot of our audience will kind of take this insight and adapt it into your own practice as clinicians. Again, thank you to all the presenters. Thank you to all of my SAIDOH officers for arranging this event, organizing the event. You know, this is really a team effort. I think that, and that's something that Chief Rader spoke about. And thank you to those in the audience as well. I know we have students from the 3 medical schools in the state. We've had PT students in the audience, nursing students in the audiences. We've had residents and faculty and staff, and we're really appreciative of this team effort. With that being said, just wishing everyone a safe and happy Thanksgiving. And hopefully 2022 is a better year for all of us. With that being said, thank you everyone and good night.